Welcome to this month's Techniques in Coloproctology virtual session number 3, Anatomical Landmarks. Is ICG necessarily required?
So excellent, and welcome everybody. This is our third virtual session of Techniques in Coloproctology. This month actually, we have the privilege of having two individuals who are going to share interesting data and experience related to lateral node dissection in rectal cancer, and particularly with the use of ICG for the procedure. Dr. Demetrios Kehagias, who has recently published a systematic review and meta-analysis on the subject, will share his data, who is now available online for Techniques in Coloproctology. And then we'll have Tsuyoshi Konishi, who's a world-known surgeon with a lots of experience in rectal cancer management and lateral node dissection in the field. So Dimitris, the floor is yours. Welcome and many thanks for connecting, and we're looking forward to hearing from you.
Thank you very much for the introduction. Allow me to introduce myself as well. I'm working in the University Hospital of Patras. It's actually the third city in Greece, the third biggest city in Greece, and I'm a young specialist surgeon. Also, I would like from my part to express my gratitude for having this great opportunity among these two outstanding professors, Professor Rodrigo and Perez and Konishi. And also, I would like to thank Ms. Emma Rodriguez and Dina Rodriguez and Emma Morris for the spectacular organization and their instructions. Should I continue with the presentation, or Professor Konishi should introduce himself?
No. Go ahead, Dimitris. Go ahead. Share your screen,
okay.
and share your data with us. I would thank you very much.
Okay. Bear with me.
This is perfect, Dimitris. Go ahead.
Okay. So the main theme of today's presentation is actually the use of ICG for anatomical landmarks detection. In this systematic review that we conducted about some months ago, we investigated actually the use of ICG during lateral lymph node dissection for low rectal cancer. As we all know, ICG is something very valuable that has emerged and has radically changed the landscape among surgery. Before we proceed with the details, as we all know, history is part of surgery. History are the foundations of surgery, of the anatomy, and we should praise at this time Dimitri Gerota, who was a Romanian anatomist, that over a century ago he described the dual lymphatic drainage of the rectum. And these findings and his discovery have been perpetuated throughout the years until today. So we all know the dual lymphatic drainage, meaning that the rectum drains either through the inferior mesenteric artery or either the middle rectal artery to the lateral pelvic nodes. And of course, we all know the third route that involves the lower rectum and the anal canal that goes to the inguinal nodes. Of course, when we talk about lateral pelvic nodes, we refer to tumors below the peritoneal flexion, since that tumors that are above the flexion, pelvic nodes are only involved roughly at 3%. Regarding the anatomy, lateral pelvic nodes are something that might frighten the surgeon because he may not be that familiar with the anatomy, because lateral nodes are not involved in the guidelines in the Western especially. So describing the anatomy, actually the area where the nodes are is a triangle-shaped area. And the boundaries are: in the lateral, we have the external iliac artery and vein. Medially, we have the ureter. And caudally, we have the urinary bladder. As we see in the picture, after the dissection, you can see also the obturator nerve and obturator artery that need to be preserved. And in this area, we have the groups of internal iliac and obturator nodes that are the nodes that we need to remove during the dissection. So if we think about the lateral nodes, someone may not recognize whether or not they are important for the oncological outcomes, but the data is out there. And for example, even from 2005, if you see this published study, you will find out that in lower rectal cancers in stage T3 or T4, lateral nodes are involved in about 17%. And this has an impact in the overall survival, as you can see in the curve, since lateral node metastasis has a remarkably decreased overall survival. Another landmark study was also the Mercury trial. This trial actually evaluated suspicious nodes and the role of these nodes that were diagnosed on pelvic MRI. Suspicious nodes based on their characteristics, their size, were about 11% in the MRI, and these suspicious nodes, lateral nodes, were also related with a lower disease-free survival. So the data and the evidence is out there, and indeed, lateral nodes have a significant impact on oncological outcomes. However, here is the million-dollar question: why haven't they received the appropriate attention? For instance, from my personal experience, as I was preparing for my exams in the specialty, I only found 2 references for the lateral nodes in treating low rectal cancer in a whole textbook. So what are the main obstacles for further researching these nodes? Basically, the main obstacle is the totally different approach between East and West. If someone searches the literature, he will find out that the whole world is literally divided. So on the one hand, we have West that considers lateral leaf pelvic nodes as a systemic disease. And if you search the TNM classification, the 8th edition, you will find out that the lateral lymph nodes are not involved in the N status. Also, the mainstay of treatment for low rectal cancers, for advanced rectal cancer, is TME with or without neoadjuvant chemoradiotherapy. And also, most clinicians and surgeons in the West advocate that lateral lymph node dissection might not offer too many benefits. They don't believe that they have promising outcomes, and they also believe that the balance between oncological outcomes and complications is disrupted. So they think that the complications such as blood loss, urinary dysfunction, increased operative time, and the modest oncological outcomes on the other side, these are major drawbacks for further implementing lateral lymph node dissection for rectal cancer. On the other hand, moving to the Far East, someone can find the proponents of lateral lymph node dissection. In the East world, lateral lymph nodes are considered a local regional disease. And if you see the Japanese Society guidelines, the 9th edition, lateral lymph nodes are involved as N3. And the suggested approach for advanced rectal cancer is TME with lateral lymph node dissection without neoadjuvant. And all these data are supported mainly by this landmark study of the Japanese Clinical Oncology Group, 0212, this randomized clinical trial that included patients without previously enlarged or pathologic lateral lymph nodes. And these patients were treated either with TME alone or TME with lateral lymph node dissection. And the findings of the study show that in the group with a lateral lymph node dissection, there was decreased local recurrence in the lateral pelvis. Also, at a follow-up of 7 years, the rate of local recurrence was 7.5 versus 12. And also, the pattern of local recurrence in the TME alone group included actually 20 more cases in the lateral pelvis, meaning that indeed lateral lymph nodes should be considered a regional disease. Delving deeper into the results of this landmark study that included this number of patients, the 7-year recurrence-free survival seemed to be comparable in both groups. However, if someone sees the subgroup analysis for stage 3 patients with advanced cancer, he will find out that lateral lymph node dissection offers more benefits compared to TME alone, with a hazard ratio of 2.17. So lateral lymph node dissection may have benefits, especially in the advanced rectal cancer. So in order to convince the West and move forward and conduct better, well-designed studies, so we need to find a solution for bridging this gap. The main reason for not promoting this approach, especially in the West, is actually the balance, as we said, between the complications and the oncological outcomes. This is the most severe drawback. And here is the position of the ICG that has emerged and changed the landscape, as we said. And if we compare ICG with this superhero for everyone who knows him, there is no similarity only in the green color, but also on this quote, because no matter how bad things get, something good is out there. And ICG is something very good. And as many editorials and articles published, ICG promises a bright green future. So based against this background, we had this hypothesis, whether the use of ICG will benefit lateral lymph node dissection in terms of oncological outcomes, while also it will mitigate the postoperative complications. Our primary endpoint of the study was the number of lymph nodes harvested, and the secondary endpoints we investigated were the operative time, blood loss, length of stay, and urinary retention. Our search strategy included the investigation of PubMed and Google Scholar databases. We used keywords and medical subject headings. Our inclusion criteria were English language, case series, case reports were included, and the comparative studies that compared lateral lymph node dissection with or without the use ICG were separately analyzed. The data extracted included patient and tumor characteristics. Regarding the lateral lymph node dissection, we assessed the detection rate, the number of lymph nodes retrieved, and the anatomic location. Also, we checked about the technical details of ICG use during this procedure regarding the dosage, the time, the site of the injection, and the route. And regarding the comparative studies that we said before, we assessed the number of lymph nodes, blood loss, length of stay, and urinary retention. Overall, we found 13 studies that were eligible. 5 of them were prospective, 5 retrospective, and 3 case reports. Regarding the studies that compare with or without the use of ICG, we had 4 studies included, and there were also 2 studies that evaluated the use of ICG for detecting pelvic sentinel nodes. These were analyzed also separately. Regarding the patient's characteristics, we had 220 patients overall. 70% of them roughly had the stage of T3, and the neoadjuvant chemotherapy was in around 40% of the patients. The N status and the neoadjuvant therapy were not exclusion criteria from our study. There were patients with N1 or N2 status, and these were included in the study. Regarding the ICG injection technique, unfortunately, it is yet not standardized, but this was expected because it's a newly implemented technique. And it seems that the most frequent concentration used is 2.5 milligram per ml with a total dosage of 1 ml. The time of injection is immediately after anesthesia in most of the studies with the use of a nanoscope or an endoscope. And usually they inject the ICG in 3 to 4 points peritumoral in the submucosa. And here I selected 2 interesting pictures to see briefly the procedure. In the left picture, after the ICG injection, you see the green lymph node. So you detect the area of the lateral lymph nodes as we described before. And you can see in the last picture, the triangle-shaped area that is fully dissected. So with the guidance of ICG, you can have a meticulous dissection protecting the anatomical structures. In the right picture, you can see how close the lymph node to this artery is and how you can separate and dissect, protecting simultaneously the artery. So regarding the number of harvested lymph nodes, here there are the 11 studies. 2 studies, as we said, were for sentinel nodes. The overall detection rate was a remarkable 80%, and a mean number of 12.9 lymph nodes per dissection were retrieved. The anatomic location of these nodes was mainly in the internal iliac region and the obturator space. So regarding the use of ICG for sentinel node detection, we had 2 studies, 46 patients overall. A mean number of 2 lateral pelvic sentinel lymph nodes per patient was retrieved, and the location was mainly in the obturator and the internal iliac space. So you can understand that we know the location, we know where these lateral nodes, lymph nodes are. We need to standardize the technique. Moving forward to the comparative studies that compare lateral lymph node dissection with or without the use of ICG, we had 3 retrospective and 1 prospective study, a total of 119 patients in the group without ICG and 158 in the other group. The parameters compared between these 2 groups were the number of lymph nodes, operative time, blood loss, hospital stay, urinary retention, and conversion rate. Here are the 4 studies. The comparisons were retrieved from each study separately. So, regarding the number of harvested lymph nodes, in all the studies, there was a statistically significant importance in the ICG group, with a mean number ranging from 11.5 to 19.2. As far as the operative time is concerned, there were 2 studies where there was statistically significant increased operative time in the ICG group. In terms of blood loss, in 3 studies, there was decreased, again, significant decrease with ICG use. Regarding the length of stay, we had 2 studies with decreased length of stay with the use of ICG. For urinary retention in the ICG group, in 3 studies we had less cases, although not significant. And in the ICG group, we had 0 conversions versus 4 conversions to open in the lateral lymph node dissection alone group. These operations were performed either laparoscopically or robotically. So, having presented the data, however, there are some major issues raised. For example, ICG indeed seems to lead to increased lymph node harvesting. However, we don't have data how this is interpreted in oncological terms. Also, a lymph node that turns green doesn't mean also that it has a metastasis. So we further need to evaluate this and understand exactly the meaning of the green lymph node. And also, what about the long-term results? There isn't no data at all regarding the long-term results. Actually, in one comparative study that we have included, Watanabe reports their 3-year results with the ICG use, and they have found that in the ICG group, there is a lower local recurrence rate, 0 versus 9%, which was significant. However, it is a fact that we are still lacking in terms of oncological interpretation. We don't have evidence about overall survival, recurrence-free survival, and of course, this is a result of not having well-designed studies. Another question that comes is whether ICG provides the desired balance that we discussed between lymph node harvesting and complications. Indeed, in these studies that we compared, we found 0 conversions and less blood loss in the ICG group. Perhaps this is associated with a meticulous dissection and respect to anatomical structures. Also, regarding the less urinary retention cases, apart from maintaining the autonomic plexus and the inferior hypogastric plexus, in one comparative study, Tang showed that also with the use of ICG, you can preserve the inferior vesical artery, which also has a role for diminishing urinary complications. Also, we should bear in mind that neoadjuvant chemoradiotherapy plays a remarkable role because it affects the dissection, and the dissection is more difficult and there is an increased nerve injury. And as we said before, also another drawback is the ICG technique is not yet standardized. Although East is towards this direction, on the other hand, West has still not been convinced, and they need more data to further implement this technique. Of course, this study has several limitations. These are, as we said, preliminary data. There is a very small number of well-designed studies. The controversy between West and East is perhaps the most important drawback, and also the heterogeneity in the data lead us to not clearly define the risk of bias in these studies. So, although these are preliminary data, and ICG seems to have an important role, these results should be cautiously interpreted. So some weeks before, while promoting this virtual session, the journal Techniques in Coloproctology posed this question. From my point of view, actually, the ICG use is like an uncharted map. We don't know exactly the full capabilities of ICG, and we need well-designed studies to understand exactly its role and unlock the full potential of this valuable tool. This is the end of the presentation. Then I hope I was as creative as the team of Springer that prepared this genius visual graph. Thank you very much.
Thank you, Dimitris. I think that was an excellent presentation. By the way, I forgot to tell everyone in the chat, there is a link to Dr. Demetrios Kehagias' publication. If you're interested in downloading it, I strongly suggest that you read it because I think it was very educational. And the second thing is this meeting is being recorded and will be available online through our YouTube channel. If you're not yet registered in our YouTube channel, please do register. And if you want to see it again, you can see it at any time on demand. So yes, Dimitris, thank you very much. I think it's interesting data with all limitations being acknowledged. And we're now going to turn on to Dr. Konishi. Thank you, Tsuyoshi, for tuning in and perhaps provide us a devil's advocate to see whether you do or you do not think ICG is a useful tool yet for or during lateral node dissection and rectal cancer. The floor is yours, and we're very much looking forward to your presentation. Thank you.
Yeah, thank you, Rodrigo, for kind interaction, also giving me the opportunity to discuss about this paper. So first of all, I'd like to start why lateral lymph node dissection is attracting the attention. So this is the data from international multi-center study involving more than 1,200 cases from 12 centers in 7 countries, showing adding lateral node dissection after chemoradiotherapy seems to reduce local recurrence compared to those without lateral node dissection in patients who had enlarged lateral lymph node on the baseline. Actually, this is a first large data set showing potential benefit of adding lateral node dissection. And after this paper, there's a lot of discussion between the Western surgeons and the Eastern surgeons whether this technique is really feasible. And I first want to congratulate Dr. Dimitris. This paper is clearly attractive in terms of first systematic review on the ICG for lateral node dissection, and the results are quite encouraging, including increased lymph node yield, as well as reduced bleeding and a shorter hospital stay by using ICG in this complex procedure. Despite there are some limitations as he discussed, including relatively small number of studies, which is only 13 studies, with mostly retrospective, with a lot of heterogeneity in patient selection and techniques in ICG injection. This is a kind of reasonable because this is quite a new approach. So obviously there's a heterogeneity in the technique, but still this paper further promote us to consider what is the benefit of ICG in this complex technique. And I first want to show you how to use ICG in the lateral node dissection. Actually, this is a nice video from a Korean group, Professor Choi, who is a world famous expert of lateral node dissection with a robotic approach. So he uses ICG, injecting 1 cc in 4 directions around the anorectal junction in the submucosal layer. And as you see in this video, now he's dissecting the deepest part of the lateral pelvis. Now the lymph node is nicely highlighted and dissected carefully from inferior vesical vessels. So obviously, by using the ICG, he's doing quite a meticulous lymph node dissection with preservation of all these branches. And this is the final view. If you use the ICG mode after dissection, there's no left behind lymph node, confirming complete dissection in this area. So this video also confirms that potentially using ICG might help clearing this compartment. But I have a couple of questions before concluding ICG is truly beneficial in improving the quality of lateral pelvic node dissection. There are three aspects that I want to discuss today. The first aspect is technical aspect of lateral lymph node dissection. The second question is technical aspect of ICG. And the third, sentinel node concept in GI cancers. So first, technical aspect of lateral node dissection. The first important fact about lateral node metastasis in the rectal cancer is the distribution, anatomical distribution is much deeper in rectal cancer compared to GYN or urology cancers. Clearly, majority of the lateral node metastasis exist in the deepest pelvis, distal obturator, and the internal iliac areas, which is much deeper compared to shallower distribution in GYN or urology cancers. And actually, according to the data from Tokyo, 44% of positive lateral lymph node metastases occurred in this distal compartment at the pelvic bottom. I will show you a very interesting case. This case has the right side positive lateral lymph node, and this figure appear to be a complete dissection in the lateral compartment. But when we look at the specimen, there's no positive lymph nodes. So when we look back the laparoscopic view, camera view, actually I found positive lymph node stuck to the inferior vesical vessels at the deepest pelvis. So we needed additional resection with a combined resection of the inferior vesical vessel. So this is the one example how deep this positive lymph node is located in the lateral compartment. It is always important to check the specimen for positive lymph node. Otherwise, regardless of using or not using ICG, you may miss the positive lymph node left behind. And this is actually the view after lateral lymph node dissection. You see all the structures like umbilical artery here, ureter, and the vesical artery, and the inferior vesical artery. All these structures are nicely exposed. And importantly, the most common site for the metastasis is located at the deepest pelvis, behind the internal inferior vesical vessels around this area. So in other words, when we need to completely dissect the most frequent site of the metastasis, which is located in the deep pelvis, anyway, when we approach from the abdomen, we need to completely clear the entire compartment. That is number one point. Unless we completely dissect this area, we cannot reach to the pelvic bottom. So number one question is, even if we use the ICG and nicely visualize the lymph node in the lateral compartment, actually it does not significantly change the procedure. Anyway, when we do lateral node dissection, we need to clearly dissect this lateral compartment. Otherwise, we cannot dissect the deepest part of the pelvis where the metastatic node is located. And rather than using the ICG, I weigh more importance on anatomical landmark when I do lateral node dissection. And it is all surgical planes. The number one plane is a lateral plane composed by pelvic muscle, which are psoas muscle and obturator internus muscle. The second plane is a medial plane composed by autonomic nerve and the ureter and the urinary bladder. And the third plane is the posterior plane composed by internal iliac vessels and the sciatic nerve. So basically, these three planes are to be exposed to do complete dissection of the area. And there's an internal iliac vessel running in the midst. And the most important part, or in other words, the most frequent site of the metastasis is around this area at the deepest pelvis. So obviously, you need to understand the anatomical landmark to clear these lymph node. The second technical aspect of ICG. So this is the data from Dr. Choi. So they introduced using the ICG in the lateral lymph node dissection, and they showed increased harvest increased number of harvested lateral lymph nodes by using ICG. However, important fact is, although it increased the number of the negative node, it did not increase the number of the positive lateral lymph node. This is another data from Japan by Dr. Watanabe. They also investigated with and without ICG in the lateral node dissection. And again, ICG increased the total number of harvested lymph nodes, but it did not increase number of positive lateral lymph nodes. Actually, this is not only lateral lymph node. There's a randomized trial, a very interesting randomized trial, which looked at the number of harvested mesorectal lymph node in the sigmoid and rectal cancer. And again, this data also showed ICG increased harvested lymph node in total, but it did not increase the positive lymph node. So clearly, the positive lymph nodes are not actually more harvested by using the ICG. Why does this happen? Then there's I found a very interesting in vivo and in vitro study from Japan, from Dr. Takemasa's group. Actually, this is an important fact. ICG stains only normal lymph node tissue, but not the cancer. As you see in the middle figure, the normal tissue is nicely visualized by ICG, while cancer tissue is not highlighted. So basically, the ICG visualizes the normal lymph node tissue. And if the cancerous tissue occupies the lymph node, the detection with the ICG is less and less possible. For example, when the normal structure is between 10 to 30%, actually the detection rate with the ICG is less than 20%. So this clearly means that actually, even if we use ICG, we may easily miss the positive lymph node. And this is a potential one reason why using ICG does not increase the number of positive lymph nodes. And also, the visualization of ICG is affected by multiple factors. Actually, from this study, actually they looked into what is the optimal setting for using ICG in lymph node mapping. And as you see, if you give too much tattooing in the submucosal area, the entire mesorectum or mesocolon is stained and there's no lymph node visible. So actually, what I want to say is the condition is very important that defines the positivity of a visualization as well. And there's a lot of lessons that we can learn from perfusion analysis. In ICG, for assessing the blood perfusion is much more investigated, but it's not a simple positive or negative perfusion. As shown in this Korean group, actually the steepness of the enhancement is more important than positive or negative. And when we carefully look at the positivity of the ICG, actually there's quite a gradation from a thick part to a very thin part of ICG staining. And this represents good blood perfusion, no blood perfusion, and in between blood perfusion, like poor but not negative perfusion. So we don't really know what this less perfused, less stained ICG means, especially in the lymph node mapping. And this is another study. Actually, the quantitative ICG perfusion is affected by multiple conditions, not only the dose or location of the ICG staining, but camera distance, ICG image mode, fluorescent image source, and the site of angiography. So obviously, this is not simple positive or negative. And what happens? What is the consequence of this quite an unstable ICG visualization? There are two major randomized trials which investigated whether ICG helps to reduce the leakage, and the U.S. study showed no benefit by using ICG to reduce leakage after low anterior resection, while Japanese study showed quite a significant reduction of leakage. So even with quite a well-designed randomized trial, the two studies showed a completely opposite result, the beneficial versus non-beneficial. So this is likely, there are multiple factors, but likely one of the reason for this opposite result could be different condition, and that clearly highlight how it is difficult to interpret the positivity and negativity of ICG staining through the camera, just because it is fluctuated by various conditions. And finally, sentinel node concept in GI cancers. This is a nice prospective study from Dr. Watanabe. They conducted the multi-center prospective study on splenic flexure cancer to visualize the lymphatic mapping. And in all 100% cases, the tattooing nicely showed the lymphatic drainage route. And this clearly showed that ICG may be useful for visualizing the lymphatic route along the vessel. But when we look at the proportion of the lymph node metastasis, actually not visualizing the sentinel node does not change the procedure, because even the proximal lymph node have quite a high proportion of lymph node metastasis, like 6% or 4%, even at the root of these vessels. So regardless of staining or not staining of the ICG, anyway, we need an official lymph node dissection up to the root of the feeding vessels. And that is the same for the lateral lymph node dissection. As I told at the beginning, complete dissection of the area is anyway needed because the sentinel node concept is not actually established in the GI cancers. And finally, node picking technique of only positive node result in even higher local recurrence compared to TME alone without doing any lateral node dissection. This is the data from a multi-center study from Netherlands. So just a node picking or partial resection of the lateral compartment is not a good idea. So summarizing my talk, ICG does not increase number of positive lymph node because ICG stains normal tissue, not the cancerous tissue. And technically, complete dissection of the lateral compartment is needed anyway, because sentinel positive lateral lymph node is always located at the deepest pelvis. And finally, visualization of the lymphatic drainage route or sentinel lymph node does not change surgical procedures. Concept of sentinel node is not established, especially when the node is positive. So final slide, future perspective. Obviously, we need a continued evaluation of ICG in lateral lymph node dissection, and we need a well-designed prospective study with a unified protocol, including all the conditions on the camera, as well as timing and the location of ICG injection. And until then, I would recommend complete lateral lymph node dissection, regardless of using or not using ICG, based on established anatomical landmarks. Thank you.
So excellent, Tsuyoshi. Thank you very much. I think it's a very interesting view and very compelling arguments, perhaps to not yet use ICG as a routine in lateral node dissection. So even though you do have access to this technology, do you ever use ICG for this purpose when you're doing a lateral node dissection or not? That's my first question.
So I do not use ICG for lateral node dissection.
Okay. And I know we're good friends of Professor Che, and we know that he has an ongoing study, and he shared preliminary data from his study and his views, and we know that he uses ICG for this particular purpose. And I remember that when I was in Japan, the gynecologists were also using ICG for their lateral node dissection, even though I understand that the lateral node dissection that they perform is a quite limited one. Do you see any use for any specific purpose for these patients, or this is something absolutely experimental at this point, and we should leave for clinical randomized trials or clinical studies? What do you think?
So my point is, number one, it's actually, so technically speaking, the lymphatic route or lymph nodes are quite nicely visualized by using ICG. I think I agree on that point. But the problem is it does not change the procedure, right? Because anyway, we need a complete dissection. And the other concern is it does not stain the real positive lymph node. That's the point. So especially when the cancer occupies the lymph node more than like maybe 70% of the lymph node structure, the detection rate with ICG is quite low, according to the study by Dr. Takemasa. So obviously, we need more study on this, how to really detect the positive cancerous lymph node in here. Otherwise, it would not actually add any benefit on this procedure.
Yeah, what you're saying is it may actually blur and make us look for the negative nodes while leaving the positive nodes inside because they don't stain. So we have a false feeling that there is no additional node to be resected, but you might be leaving the metastatic node itself inside.
Right.
That's a very compelling argument. Let me ask Dimitris, are you using, number one question is, I know you did the study, doesn't mean your experience with the technique. My question is, number one, do you perform lateral node dissection, and do you actually use ICG, or is this something just a subject of research, and you're still not doing this in Patras?
Unfortunately, we use ICG only for checking the anastomosis in colorectal surgery. Regarding lymph nodes, we don't use it at all.
Okay.
Actually, I learned the procedure by studying the literature.
Okay, excellent. All right. So, Tsuyoshi, thank you very much. I'll open the floor for any questions. If somebody has a question, we're about to reach 1 hour session. I think it was a very productive session. I learned a lot, and a very interesting data from Dimitri, and actually very interesting counter arguments from Tsuyoshi. I'm still not convinced that ICG is to be used at this point, but I think it's an avenue of research that we should definitely pursue, and I hope to see more data in the future.
Yeah, also, I think, we can expect more, improvement in the technology as well. So obviously, this is promising, right? So we need to explore how we can use this technique to actually, for example, how to detect a positive node. These are something we can explore more. Yeah.
Excellent. Okay. So I want to thank you both for sharing your data and for connecting. I know it's a lot of time and preparation. Dr. Demetrios Kehagias, thank you very much, and congratulations on your publication. Tsuyoshi, I think you did a fantastic job in showing some very interesting data. It was very informative session. I want to remember everyone that the session has been recorded, and the chat has the link for both the YouTube channel and Dr. Kehagias' publication on the use of ICG in lateral node dissection. Thank you everyone for connecting, and I hope to see you soon next month with the 4th virtual session for techniques in coloproctology. Good night, and thanks again for connecting.
Thank you. Thank you, Rodrigo, and thank you, Demetrios. Thank you, everyone.
Bye.
Thank you.
Thank you for watching. Be sure to subscribe and join us for our next virtual session.